Good morning, fellow nurses, professors. My name is Althea, and today I will be presenting an actual patient who I looked after in the community and has been known to me for close to 15 years. We will call her Cindy. She has COPD, and she was 52 years old when we first met for her first alpha-1 augmentation treatment. So Cindy used to live out in the country, but she's now 68 years old and her needs have changed. So she decided to move closer to where family is and closer to facilities that could help meet her healthcare needs. So she decides to go to an independent living. My preceptor is actually the director of the retirement community where she now lives. The facility has 200 employees and is taking care of about 400 clients with needs varying from, independent to assisted, long-term, memory care. Name it, they have it. But there are several reasons why I chose this particular case. And one of this is because of my familiarity with Cindy and Cindy's case. We have been together for close to 15 years. I'm still doing her treatments. And I promised her that I would try to increase awareness on alpha-1. And so here I am. Second is that because COPD, although common, COPD in the background of alpha-1 antitrypsin deficiency is under-recognized, and it is my goal to increase public awareness about this rare disease. And finally, it's because of my background in critical care and biotherapy that I think it is appropriate. I am in direct care of these patients, and I want to impart this knowledge. My goal is to keep everyone engaged in my presentation so that by the end of 20 minutes or so, we would all have a better understanding of the factors that lead to the development of COPD, as well as the diagnostic tools available to rule out all the possible differentials for shortness of breath, cough, mucus production, all the hallmark symptoms of COPD. It is also my intent that by the end of this, we would be able to prioritize our clients' needs and be able to come up with a good treatment plan that is not only individualized but evidence-based and with the help of an interdisciplinary team. Finally, I hope to accomplish what I've come here to do, to spread awareness on alpha-1, the value of augmentation therapy and smoking cessation in optimizing clinical outcomes. So let's learn about Cindy. She is 68 years old, female. She's Caucasian, never married, a retired factory worker. Just take note of all those demographics. So let us discuss the risk factors that predispose Cindy Lou to developing COPD, both non-modifiable and modifiable factors. Although typically COPD is a disease diagnosed in people over the age of 60, Cindy was actually diagnosed at 50. And according to a research by Devo that came out in 2022, early in 2022, young COPDers have a 9-fold increased mortality risk. And it is significant with a p-value of less than 0.0001. That's 3 zeros. And so that is pretty scary. Women like Cindy Lou are 37 more likely to have COPD than men. They are more likely to die of COPD or have more severe COPD, especially if they live in Western societies. This seems to be a different thing from the impression that COPD dominates in men. That's only true in Eastern societies like the Philippines, where I come from. It might be related to the higher rate of cigarette smoking in women here in developed countries like the US. Take note that 12% of the women population in the United States smoke versus the 2.2% in China. Now, as far as her genetics is concerned, her alpha-1 was diagnosed about 3 years after her COPD diagnosis, after a genetic screening. That long delay of about 5 to 7 years. Hers is actually was diagnosed pretty early, like 3 years is pretty early, but typically it's 5 to 7 years between first symptoms and initial diagnosis of alpha 1. And that's not unheard of. In fact, it's typical because of the lack of awareness. This is critical because a diagnostic delay that long is associated with worse clinical outcomes at the time of the initial diagnosis. And do you know that at 54 years old, Cindy was told that she needed a lung transplant, which she vehemently said no to. And I'm glad because 14 years later, here we are, she's doing well. And we can thank augmentation therapy or enzyme replacement therapies for that. Now, as far as her modifiable risk factors, she was a 20-year, one-pack per day ex-smoker and a factory worker, and she loves to grill a lot, especially in the summer. Her diagnosis of COPD came after a CT scan, which confirmed all the damages that was wreaked by COPD on her poor lungs, including the hyperinflation of the sacs and the narrowing of the bronchial tubes. While this gives the practitioner, us, an idea of the damage that spirometry cannot detect, pulmonary spirometry actually gives us the idea of all the functional abilities of the lungs left given all the damages done by COPD on the lung tissues. So we came to visit Cindy for her Medicare annual wellness visit check, and she tells us that she's on her 5th day of her worse than usual cough, and that she's been passing thick yellow phlegm that's hard to get out. She also has increased her oxygen from 2 to 3 liters because it's been taking longer for her to recover when she walks to and from the bathroom, and she's also been feeling feverish. So her review of symptoms revealed, besides her low-grade fever, a loss of appetite, some fatigue. She has no cardiovascular symptoms, but a heart racing or tachycardia, perhaps because of the frequent use of inhalers or the disease process itself. She denies GI symptoms and urinary symptoms and has no temperature intolerance. Moreover, subjectively, further history reveals a disturbing family history of emphysema with her mother and a liver disease with her brother, who died very young and was never a drinker. Sounds very fishy, right? Sounds like alpha 1. Smoking is the biggest risk factor for Cindy for the development of her COPD. It increased both her risk of developing it and dying from it. Approximately 85 to 90% of COPD cases are actually caused by smoking, and female smokers are nearly 13 times more likely to die from COPD than women who have never smoked. The good thing about Cindy, though, is that although she has all these predispositions, she keeps up with her annual physical screenings, vaccinations. She eats rather healthy. She doesn't exercise, but she does go to her doctor, and she's got good compliance when it comes to her medications and treatments. Cindy does not have any medical allergies, but she does have seasonal allergies, and she takes Allegra 180 milligrams for it daily. For her COPD, she is on short-acting bronchodilator called albuterol. She's also on Breo-Ellipta, which is a combination inhaled corticosteroid and ultra long-acting beta-adrenergic. She's on Spiriva, which is a long-acting antimuscarinic, and Duaneb, which is a combination short-acting antimuscarinic and short-acting beta-adrenergic. This treatment plan is actually aligned with the most current gold guidelines, which was updated this year, 2023. The update actually calls for the addition of ICS to a SABA-LABA regimen for patients with more frequent exacerbations because of eosinophilia too. Of course, she is on intravenous augmentation therapy with Aralast, which she receives weekly at 60 milligrams per kilogram, and she is on emergency drugs just in case reactions happen during the treatment. She is also on several antihypertensive drugs. As far as Cindy's physical examination goes, her vitals are showing that she is struggling a little bit. Her blood pressure is a little high, 138/68 is a little high for her. She's slightly tachycardic, probably because of the slight fever, the disease process. Probably is from her treatment because she's been using her inhalers a little bit more frequently. And she has desaturated about 4 points from her baseline, which is usually at around 91%. Speaking takes an effort for her as she was stopping here and there to take a breath. But it's worth noting that she had no jugular vein distension or very significant swelling on the lower extremities that would indicate cor pulmonale. She's a little hypoperfused. Her skin is a little bit cool and dry. But most significantly on her physical examination is her breathing. Her breathing is labored at rest. Normally she's got shortness of breath on exertion. She's positive for expiratory wheezes on both anterior and posterior aspects of both lungs. Her chest expansion is normal. The trachea is midline. Her oxygen demand has increased, so she is now on 3 liters as opposed to 2. There is no orthopnea. And otherwise, all the other assessments are fine. She is awake, alert, oriented. She participates actively. Her responses are appropriate. And her memory and comprehension is intact. So because we were doing an annual visit check on Cindy that day, we actually had labs done the day before. So we are fortunate to have these information with us because she has, it looks like, an elevated white cell count of 14.8, which would indicate a possible an infective component of the exacerbation. Otherwise, everything is okay. So in view of her symptoms and her history and the pattern of more frequent exacerbations during the winter, we treated her condition as a COPD exacerbation, which has all the elements of the gold definition for an exacerbation, which is an event characterized by dyspnea, cough, and sputum production within 14 days. Among the differentials are chronic bronchitis, pulmonary embolism and edema, cystic fibrosis, bronchiectasis, pneumonia, and heart failure. And avoidance of triggers and adherence to vaccination and COPD treatments. Now, just a little bit of something about alpha-1 antitrypsin deficiency. It is a genetic disorder affecting just 1 in 2,500 people, and it's primarily a disease of the liver where the enzyme is produced. Alpha-1 protects your lungs from elastase. It's that enzyme that destroys elastin, which is necessary for the lungs' ability to recoil. Hence, a deficiency results in a decreased lung recoil and air trapping, which are the mechanisms that cause emphysema. There are only about 100,000 people affected in the US, and we know that that is an underestimation because not everybody who has alpha-1 develop any disease that's associated with it. But when it manifests itself, it could manifest as a liver disease in young children. It could manifest as a lung disease in the middle-aged population. And it could manifest as a skin disease, like panniculitis. Here is a little segment on augmentation and enzyme replacement therapies. They're both one and the same thing. Because alpha-1 antitrypsin deficiency is classified as a rare disease, which is defined as an uncommon disease affecting less than 200,000 adults that's geographically dispersed. A lot of most alpha-1 studies are inherently small and are often not considered generalizable just because of their size, but it's rare. So how do you actually prove that it works? Well, according to Dr. Stoller, who is the forefront rare disease expert on alpha-1 antitrypsin deficiency, he states that generalizable observations from rare diseases like alpha-1 emerge from experience with alpha-1 antitrypsin deficiency. Experience is the best teacher. There are a lot of studies out there, small ones, of course, longitudinal and cohort studies, and in 2019, in a study led by Elvis, it was concluded that augmentation therapy works. This study actually reviewed all the studies done to evaluate the efficacy of enzyme replacements. And in conclusion, Ellis actually stated with his colleagues that augmentation and ERT increases the chances of survival or time to lung transplantation when compared to those who are augmentation naive or did not get ERT. Well, I started Cindy 14 years ago on enzyme replacement treatments. She was 54 years old. Now she's pushing 70. So I think that's proof. Don't you think? Before I wrap up my presentation, I will leave you with these two questions and wish that you have learned more about not just COPD but alpha-1 in general. And I am hoping that when you become nurse practitioners, you will always remember and consider testing your new COPD patients for alpha. The first question is, what do you think is the intervention with the biggest impact on clinical outcomes in patients with COPD in the background of alpha-1 antitrypsin deficiency? The second question is, what is your biggest takeaway from this presentation and why? What's your favorite part? Just a fun fact, this zebra is the symbol for rare diseases, and there is actually an organization for rare diseases, and you can donate towards the treatment of patients with rare diseases. This organization is called the National Organization for Rare Diseases. It's actually one of my charities. And then, of course, the other one is Alpha-1 Foundation. And it's always color purple because purple is the color of alpha. If you have any questions, you just let me know. And I thank you very much. And this is from Cindy and I. You take care. Bye-bye.